Thank you all to, especially the Defeat Duchenne staff for having us at this meeting. We've supported this meeting for a number of years now, and it's always a great meeting to come to and engage with the Canadian community. So my name is Jordan Messer. As the other Jordan indicated, I've been with Dyne for about 2.5 years now. I've really enjoyed getting to know this community and getting to know this space. It's been a very fulfilling job thus far for me, and I'm looking forward to continuing to do that and talking to you about zalesiment rostudirsen. I know that's a mouthful. Some of you might be more familiar with the name Dyne 251. So we've sort of shifted and gotten our generic name approved by regulators around the globe. So moving forward, we're going to make this asset known as zalesiment rostudirsen. Again, it's a mouthful, so I'll probably start to say Z-rostudirsen, as you might notice. But old habits tend to be tough to get rid of, so if I say 251, please forgive me. But I'll be talking a little bit today about this program and this exon skipper that's designed for exon 51 skipping in males amenable to that specific exon skipping mutation. So I'll be going over our data a little bit as well as our technology platform. So just a quick word on Dyne before we get started. So we're really on a mission to deliver functional improvement for individuals, families, and communities. We know that the ultimate treatment goal is functional improvement for Duchenne and other rare neuromuscular diseases. And across our programs, as we're making program level and study level decisions, we always try to keep this in the front of mind for whatever we do. And just a quick word about our technology platform. So we call this the FORCE platform. So this is really the basis for all of our different programs at Dyne. And it's really comprised of 3 different components. So the first is not a full antibody, but an antibody fragment, which you see in the red and the blue here. So this is really the key in overcoming some of the challenges that have been seen with the first generation exon skippers, namely not delivering high levels of drug to all the affected tissues that we see in Duchenne. So we've really sort of designed this platform to overcome that challenge. And there's another component, so the linker. So it links our antibody fragment to our payload. In this case, the payload is a exon 51 skipping antisense oligonucleotide, that sort of what Dr. McAdam mentioned. And the interesting thing about our platform is that it does target a specific receptor that's highly expressed along all muscle cells, including the heart and the diaphragm. So it's sort of, again, the key to unlocking that higher level of drug delivery into those specific tissues. So when we think about other programs that we're looking into, there's sort of a nice versatility with this platform because, as I mentioned for DMD, we're looking at an exon 51 skipping payload. But if you take another condition such as Pompe disease, for example, for which we're looking at preclinically right now, we can also attach an enzyme, so a larger molecule, as that biologic payload. So Dr. McAdam did a really nice job explaining what the concept behind exon skipping is, so I won't belabor the point, but just want to highlight again that for Z-rostudirsen, we'll be looking at specifically those individuals with mutations amenable to exon 51 skipping. So the idea is that you remove the exon 51 and you're able to produce a shortened but functional near full-length dystrophin protein. And just going off of dystrophin just a little bit more, I'm sure this room is well aware that Duchenne's not just a skeletal muscle disease. There are multiple different organ systems that are involved within the process. So if we talk about what was mentioned a little earlier today, so some of the CNS and neurologic manifestations, those are present in Duchenne. And then as we go down to the different organ systems, GI, dystrophin's present in smooth muscle, which is along the intestines. So all of these different issues can pop up across these different organ systems in Duchenne. So it's really important if you're delivering a therapeutic drug, in this case a dystrophin restoration therapy, that the drug's able to reach all these different components or organ systems in the body, and with the goal of producing dystrophin to help alleviate some of the symptoms that we see across the different organs. So here we'll transition to our ongoing phase 1/2 study. So this is called the DELIVER trial, which we're looking at zolesiment rosudirsen in males with DMD mutations amenable to exon 51 skipping, as I mentioned. And just to orient you to the slide a little bit, so starting on the left-hand side, this is sort of a diagram and how the study started. This was sort of the dose finding portion of the study. So the purpose of this was to define the most safe and efficacious dose. And our go-forward dose will be 20 milligrams per kilogram given every 4 weeks, so it's dosed once monthly. This is a big differentiator from the other first-generation exon skippers that comes as a result of our platform being targeted to deliver more PMO or antisense oligonucleotide to muscle. So for purposes of this presentation, for our functional outcomes data, we'll be focused on the 10 and 20 milligram per kilogram doses, and I'll also be showing dystrophin production from our 20 milligram per kilogram dose. So the placebo-controlled period of the study is 6 months. So after that 6-month period, individuals in the placebo group were switched over to active treatment with Z-rostudirsen for the duration of the open label extension and long-term extension. So we did study, and we are studying a fairly broad range of participants here. So we're looking at participants aged 4 to 16 years. They can be ambulant or non-ambulant at baseline. And we do have several non-ambulant patients in this study, which we'll be certainly looking at as we analyze the data. But just being a first-in-human study, we're looking first and foremost at safety and tolerability, and then also a co-primary endpoint of change from baseline dystrophin levels at the end of the 6-month placebo-controlled period. So as I kind of alluded to earlier, we are also looking at function here. So we're looking at NSAA, which Sarah very nicely explained in the previous presentation, as well as SV95C, and also other time and function tests, which we'll get into here shortly. So just an update for where we are right now. So we're currently collecting data from what we're calling the registrational expansion cohort. So this is a cohort of 32 patients. It's a 3-to-1 randomization. So there will be 24 participants dosed with Z-rostudirsen, 8 with placebo. And we're currently in the placebo-controlled portion of that right now. The primary endpoint's the same. It's safety and tolerability, as well as change from baseline and dystrophin. And then we're also going to be evaluating function, and we'll be continuing to follow these patients throughout the rest of the study. And it's really an exciting time because by the end of the year, very soon, in the next couple of months, we'll be reading out this cohort of data. So this will be sort of the basis for our initial filing in the United States. Just quickly for baseline characteristics, so I mentioned we're going to be focusing mainly on the 10 and 20 milligram per kilogram cohorts here. So I'm just looking first at age. So for the 10 mg per kg group, a little over 6.5 years old. For the 20 mg per kg group, a little over 8 years old. And all of these patients were on a daily regimen of steroids. And you can see we have one patient who was previously on eteplirsen. In the other cohorts, in the dose-finding portion of the study, we do have additional participants who are switching off of eteplirsen, so that's certainly an interesting subgroup we'll be looking at. But as you can see here, there are a number of different other baseline characteristics in terms of NSAA and timed function tests, as well as SV95C. So here's a glimpse of our functional data. So the longest follow-up we have to this point is in the 10 milligram per kilogram group. So we have out to 18 months of functional data across these different endpoints. So just to orient you to this slide, there's a lot going on. The light green curve are the patients initially dosed at 10 milligrams per kilogram, and the navy curve represents the patients initially dosed at 20 milligrams per kilogram. And what you're looking at here on the vertical axis is the change from baseline in each of these different assessments. And if you'll notice on the right, you'll notice the direction we're looking at in terms of what constitutes improvement. And so what we're seeing in general across these different endpoints, adding to the early but totality of evidence thus far, that we're seeing improvement in function across these different endpoints, which is definitely encouraging to us. Again, it's early. We don't have 100 to 200 patients at this point, but these early signs are certainly encouraging from a functional standpoint. Thank you, Sarah, for making my job a little bit easier. I don't have to explain this in detail. But we also looked at SV95C in our study as well. And we're really excited about this, the potential of these data. So again, just to orient you, on the vertical axis here, this is the change from baseline in meters per second of stride velocity 95th centile. And what is highlighted here in terms of the orange dashed line, so that's what's been proposed as the minimal clinically important difference. So the minimum level of change in SV95C that's considered meaningful from a clinical standpoint. And what you see is by month 6, both of these cohorts have exceeded that proposed threshold, and these effects are sustained out to 12 months in terms of the 20 mg per kg cohort, and then 18 months for the 10 mg per kg cohort. So again, as was mentioned, this is really a newer digital endpoint, but it's certainly promising as you have more data to pull from, because the participant wears this for a number of weeks and hours prior to the clinic visit. Moving to dystrophin, so you'll notice that this is for the 20 milligram per kilogram cohort. You'll notice that we have 2 different dystrophin levels here. The first is on the left here. So this is unadjusted dystrophin. So this is the absolute or total level of dystrophin that you get from an entire muscle biopsy sample. So what you see here is in the blue, this is 20 mg per kg again, every 4 weeks. We see a 3.72% dystrophin at 6 months. And on the right here, we're looking at muscle content adjusted dystrophin. So if you think about a Duchenne muscle, 100% of a muscle biopsy sample won't be muscle fibers. There's some fibrotic and fatty tissue in there. So what you're doing here with muscle content adjusted dystrophin is you're isolating just the part of the biopsy that's made of muscle, and you're looking at the dystrophin expression there. So when we look at just muscle content adjusted dystrophin from the sample, we see 8.7% dystrophin from an adjusted standpoint. Finally, moving to safety. So we do believe that overall we have a favorable safety profile for zolesiment rostudirsen. We have 2 potentially related serious adverse events. Both of these participants remain on study, and these events have resolved. They occurred last summer, both of them. But in terms of the most frequent adverse events, what we're seeing here is not significantly different from what you would expect with other antisense oligonucleotides and other first-generation exon skipping therapies. But I'll just point out quickly that for the infusion-related reactions, some of these can happen around the time of infusion. They're present with many different therapies that are given IV. And all of these have been mild to moderate in severity. No one is discontinued because of them, and they respond well to pre-treatment with some of your typical medications, paracetamol, Benadryl, for example. And in terms of additional safety data, we're not seeing any persistent related anemia. Our platform does target the transferrin 1 receptor, which plays a key role in maintaining iron balance. So for that reason, we are taking a careful look at some of the hematological parameters, including anemia, and we don't see anything in terms of persistent or clinically relevant anemia. And then also from a kidney perspective, we don't see any changes in magnesium or clinically significant changes in magnesium or potassium levels. So next steps, so I mentioned we have our registrational expansion cohort ongoing, and we're hoping to read that out later this year, and we're hoping to also submit for our initial FDA approval early in the next year as well, after we take in those data and analyze it. And also, it's just an exciting time for us. Beyond this study, we're of course thinking of different confirmatory studies to generate additional data for global approvals, and we're certainly well on our way to in that planning process. And just again, want to thank everyone who's been our partners in the program. We would be nowhere without our great PIs and their staffs, as well as the families who have contributed to our study. And just want to give a special thanks to our 3 sites in Canada, so Dr. Campbell in London, Dr. McMillan in Ottawa, and Dr. Selby in Vancouver.